So for disclosures, I have none. I don't make any money at all. Still a resident, as Dustin said. I plan on maybe starting to make some money to repay my loans next year. Objectives. So the 4 objectives that we have today, the first 3 are going to be in the first hour. And then the last objective will be in the second hour. The first objective is to highlight the importance of eliminating medical causes of mental illness as stated in the DSM-5. So why is this even important? Why do I even need to consider medical causes is basically my question. The second point is to explain the clinical utility of pre and post-test probability in order to arrive at the most likely psychiatric diagnosis. The third objective is how to use some simple screening tools that are in the public domain and that are free for us to use, like the stop bang, the Xanarini, the clock draw, delayed recall, serial 7s, audit. We'll go over a NIDIS scale as well to better rule out common causes of mental illness that are medical. And then the last one, the last point, we'll just mention that point next hour because that's really next hour's business. Oops, I see. Okay, so this is a pre-test. I've just kind of included, these will be the same questions in the post-test. The DSM-5 states that medical illness supersedes mental illness. And this is actually true. We'll see it in a second. The second pre-test question, we're just going to fly through these. We have a lot to cover. Is a 50-year-old male with obesity, hypertension, and insomnia presents with new onset anxiety. He and his family say that he has never had issues with anxiety in the past, and they attribute his new onset anxiety to his recent job loss. He meets all the DSM-5 criteria for generalized anxiety disorder. Which of the following is most likely true? He has a primary mental illness, and this should be addressed, or he may have a primary mental illness, but he needs a sleep study in order to rule out medical causes of anxiety first. And of course, since this is a medical symptoms in psychiatry, the answer here is B, and we'll see why in a second. But first, this first point will be very short in terms of just showing the importance of ruling out medical causes. So what I've done is I've just taken some pictures out of the DSM-5 and shown you for the various kind of the largest medical conditions like generalized anxiety disorder, depression, psychosis, that this actually is a thing, that the DSM actually has criteria E in this case for generalized anxiety disorder that says that the generalized anxiety disorder is not attributed to the physiological effects of a substance or another medical condition. So the hyperthyroidism, if a person had that, would be the cause of the anxiety. It wouldn't be a generalized anxiety disorder per se. Now, can someone have hyperthyroidism and also a generalized anxiety disorder? Yeah, that's definitely possible as well. And then the question becomes, how do we differentiate those two? And that is the second point of this lecture. So just hold on to that question and we'll get to that question in a bit. But just to show you some more that this is actually a thing, criteria C for major depressive disorder. The episode is not attributable to the physiologic effects of a substance or another medical condition. So again, it's not depression if it's due to sleep apnea, if it's due to hypothyroidism or something like that, but they can have co-occurring disorders. Manic episodes, could mania be due to this? Yes, criteria D, the episode is not attributable to physiologic effects of a substance or another medical condition. So literally they're just copying and pasting this. And this is true for every single disorder, schizophrenia. And really, if you just go through the DSM, this is an exhaustive list, but I just wanted to show you that this is true for each of the kind of the major disorders that we see. So then what are some of the medical causes of psychiatric illness? Well, this is a complicated question. Here's a book. You can see at the top, this is page 1, the cover of a 1,813-page book. So this goes into a lot of depth. And in this book, it's an amazing book. If you want to fall asleep at night, feel free to read it. They have lots of uninteresting charts and tables that tell you what labs you can order for various causes of mental illness. Like in the case of anxiety, we'd order some blood, we'd order a thyroid, we'd order a urine tox, because it could be, of course, drugs. We'd order some glucose, ABG. This is excessive. They're taking blood gases now. I have no idea why they're recommending that. That's kind of excessive. sodium, calcium, magnesium. So they're getting all your electrolytes. And then they're also checking urine for metabolites. This is actually for a super rare, like, kind of tumor. This is a workup that is very comprehensive. I think most of the time it'll be negative. But, you know, just to say that this stuff is out there and that there's big textbooks. Here's another textbook on it. This is a 731-page textbook, a little more accessible. Handbook of General Hospital Psychiatry. Here is some organic causes of psychiatric symptoms. In medicine, we, for some reason, always memorize these cute mnemonics, like victims die. Like, oh, you might have a medical cause of psychiatric illness. I think I remember the mnemonic. It's victims die. And then the patient goes, what? So yeah, this isn't stuff that you typically say out loud, stuff that you just maybe think about. But I mean, no one really memorizes this. So, you know, it could be a stroke, you could have a UTI, you could have cancer, you could have hit your head, you could be intoxicated with alcohol, you could have low oxygen or all these other disorders. You could have, your brain could be swelling due to excess pressure. You could have, you know, a dementia type of illness. You could have lupus, as Dr. House always says, or you could have some form of epilepsy. So it's just good to know, you know, I just put this in here, not so that we memorize this. I don't have this memorized. I just put it in there to say, you know, this stuff is actually pretty complicated and I don't know all this. And I've now done this for like 10,000, 20,000 hours, somewhere around there. And so this is actually really complicated, and we're just going to go over kind of the high points. So it's just kind of a lesson in humility that, you know, we might think that this is garden variety depression, but we always need to keep our mind aware that it might not be, that something else might be going on. So that's our first point, just to show that it's important to eliminate medical causes of mental illness in general. The second point is then, how do we do this? Like, how do I know what the most common cause of someone's mental illness is? And then how do I know if they may even have two types of mental illnesses, or a mental and a medical illness? How do I figure all this out? So here's some questions to get us thinking. A 50-year-old male has a new onset suicidal thoughts with plan to kill himself, and he is post-op day 5. What is the most likely diagnosis? And we'll see that the most likely diagnosis in this case is delirium. And it isn't magic that I know this, it's something called pre-test probability. And we'll go over this in a second. Here's another one. A 22-year-old medical student presents to the emergency department with psychosis. He has a history of ADHD, and he states that he's been using his girlfriend's Adderall in order to study it in addition to his own. He does not know the exact amount of Adderall he is taking, but he states he has been taking over 100 milligrams a day. What's the most likely diagnosis? So he's, you know, he's psychotic, which is a broad category. It's symptoms, it's not a diagnosis. Psychosis could be due to schizophrenia, it could be due to delirium. But in this case, with, you know, the Adderall in there, it makes me wonder if maybe it's substance use. And that should probably be the thing that we rule out first, especially if this is the first time he's ever experienced it. A 60-year-old male has morning headaches, snoring, hypertension, and he presents with subacute onset depression for the past 5 years. His stop bang score was scored as high risk. What must be ruled out? And in this case, stop bang, we're going to learn, is a scale that we can use. And if that's positive, what we really need to rule out is sleep apnea. And there's other hints in here that it's also sleep apnea, the headaches, the snoring, the hypertension, and the depression. These are all true of sleep apnea. So those are all hints that this is probably sleep apnea. So then how do I do this? How does this become easy? This is kind of my method. This really isn't taught per se, but I've kind of, I guess, thought about it. And then I've thought, how do I come to this with any kind of sense that I'm actually doing good and I'm actually trying to arrive at the right thing? And so this is kind of the system that I've created. And it exists, it's out there, it's evidence-based. So the first, so we don't want to be like Dr. House here. And we don't want to say, what could it be? Well, they could have a sore throat. They could have a discharge. And he just throws all these crazy things up on the chalkboard. Lupus is always there. And lupus can cause everything. That's why it's always there. But is lupus really likely? That's the question. And the answer is pretty much it's not. unless you're a rheumatologist, and then it is always lupus, because that's literally what you do. So there's pre and post-test probabilities. We'll see how longitudinal and family histories go into this scales. And then ruling out medical causes with labs, tests, and imaging. This is more stuff that I would do, but just so you have a general understanding of how this plays a role in kind of everything. Because at this point in psychiatry, actually, there's no imaging that can definitively diagnose anything. So although we know there's brain changes with schizophrenia, you lose 2% of your brain every year for the first 5 years, 10% of your brain total. There's no, even though we see that imaging, that's not diagnostic. Really, it's everything in psychiatry is still a clinical diagnosis. And these labs, tests, and imaging are just basically making sure nothing else is going on medically, but it's not creating the diagnosis. That's all coming up to these first three things above. I don't know. Oh, I'm going backwards. Okay. So what is pre-test and post-test probability? So there's this really fun metaphor that they say in medical school, and it's the example of hoofbeats and trying, and we can use this to explain what pre and post-test probability are. So if you're just wandering around the street and you hear hoofbeats, what is it? It's probably not a man with coconuts banging them together behind a man that's prancing along like he's a horse, right? Like in this movie. It's probably not that. Now, could it be that? Could it be a man with coconuts banging them together, making the sound of hoofbeats? It definitely could be. But is that what you're going to say most of the time when you hear hoofbeats? You're going to be wrong most of the time. Most of the time when you hear hoofbeats, it's going to be a horse, right? That's what it's going to be most of the time you hear hoofbeats. Now, that's your pre-test, right? You just hear hoofbeats. You just have a 50-year-old man with snoring. What's the answer? A 50-year-old man with snoring? It's sleep apnea, right? So this is just something that you pick up because you know this snoring thing is really strongly associated with this obstructive sleep apnea thing. And this is just something we do over time, right? If I go out into the world and I hear hoofbeats and I see a horse, and I hear hoofbeats and I see a horse, and I hear hoofbeats and I see a horse, I get this idea in my head that every time I hear hoofbeats, I see a horse, right? So the same thing is true in medicine. If I go out there and I see someone snoring and I do a sleep study and they have sleep apnea and I do, right, then we can find that these things are associated together. Now, what changes is we also, unfortunately in medicine, have to worry about the guy running behind someone with the coconuts, right? So there's other scenarios, and this is the stuff that we're trying to rule out in our interview. So let's say you're hearing hoofbeats and you're wandering around an equestrian center. Basically what I've done is I have shored up my hypothesis that it's a horse, and I've said, you know what, I'm like almost, like I was certain before it was a horse, and now I'm like dead certain. Right? It's definitely a horse. I'm at an equestrian center. This is where horses live, for goodness sake. It's still a horse. But let's say I hear hoofbeats and I'm wandering around the African exhibit at the San Diego Zoo, right? Now it could be something different. Now I might be thinking, you know what? It could be a horse. Horses do live in Africa. But now I'm beginning to think maybe it's a zebra. And so you don't want to say that everything's a zebra, but you always have to keep the zebras in the back of your mind. Does this kind of make sense? Just to illustrate this point. So then how do we know what the pre and post-test probabilities are for the various disorders in psychiatry? That's really the question, right? Like take depression, for example. Well, let's say a patient just walks into your office with depression. What am I thinking? I'm thinking a couple things. I'm thinking it could be borderline personality disorder, especially if they're younger, because borderline personality disorder tends to burn out when patients are older. The average patient in an outpatient setting is going to be about 10% borderline personality disorder with depression that we see. Now, this is going to change depending on the setting. If you go inpatient, it's more closer to like 30, 40, 50% actually. So in the inpatient setting, you're going to see even, I would expect even more people with depression to have borderline personality disorder. Especially, like I said, if they're young. What else could it be? It could also be obstructive sleep apnea. People with depression, 30 to 40% of those have sleep apnea. So that's 1 in every 3 patients with depression have sleep apnea. So I don't want to miss this because this is a lot of people, right, that walk into my office with depression. What else could it be? A lot of people love marijuana. A lot of people have hit their head. Some people have seizure disorders. A lot of people have diabetes. And actually, after having a chronic disease for like 5 to 10 years, about half of those people have depression. Now, this is going to be indistinguishable from any other depression, but it gives patients a reason to understand why they might have that depression. And if this is a patient that's had diabetes for a long time and now they're older, you know, I might just float that idea. This actually could just be to you having a disease, and that disease is kind of wearing you down a bit. And that takes some of the burden off of them thinking that it, you know, it's something that's bad with them or something like that. Now, we've changed settings. Like I say, this is a patient walking into your office with depression. Now, let's say a patient is hospitalized in the ICU with new onset of depression. What's the most common thing in this case? Now the diagnosis is delirium, and this is because 80% of patients in the ICU have delirium. So if I said, you know, this is borderline, I mean, this patient is in a coma, so I don't even, usually the patients in the ICU are totally out of it, so I don't know how I'm even coming up with that. But it's going to be delirium pretty much because 80% of patients have this. So essentially all pretest probability is its prevalence. How prevalent is this disease? How much is it out there? And how much is it in this setting versus that setting, right? How much is it in my outpatient clinic, like I'm going to an equestrian center, right? Where I expect to see a bunch of horses, borderlines, obstructive sleep apnea, versus, let's say, the zoo, which would be more like, let's say, the ICU, where I expect to see more delirium or something like that, like a medical cause. Now, let's say out of these patients who snores walk into your office with depression, we've already hit this. Well, before they snore, the odds are 30 to 40%, right? This is before they're obese and they have a thick neck and they're older. So before they snore, the odds of them having sleep apnea is 30 to 40%. Now they're snoring, so the odds just went up. So this is an example of not just a pre-test probability, but also a post-test probability because I've been given new information, they're snoring. So it's giving you both of those points there. So that's it for pre and post-test probability. Essentially, it just comes down to prevalence. The way you learn prevalence is just by practicing, right? That's one way. So there's 2 ways to learn prevalence. One is just by practicing and seeing what's out there and trying to screen for as much as you can and saying, you know what, in my practice, I just seem to have a lot of people that smoke marijuana. So I really need to make sure that they're not smoking marijuana. Or I have a lot of people that snore. Or I have a lot of people that just came from the ICU, in which case it's probably delirium. And then the other way is just by reading, right? So you open up a textbook and you say, what is the probability of this disease? Like, you know, schizophrenia, the probability is 1% in the United States population. But walking into my office, the probability is going to be higher because in mental health, we typically collect people that are more sick, right? See people that are actually seeking help. And so that probability is going to change. But knowing where it is in the population and knowing where it is in your office is really helpful. And there's studies for all this stuff. But I'll try to make it easy in future lectures and always tell you the pre and post-test probabilities of things so we can get a good idea of what it's like. Another thing we can do to differentiate is using longitudinal history. So let's say they're doing drugs. Great. Well, not great. But let's say they're doing drugs and they're psychotic. Well, now they really could still have schizophrenia, right? They could have schizophrenia. How do I know that it's not the drugs? Well, there's 2 ways, and it's by looking at them over time. If they stop the drug and they keep having psychosis a year later, 2 years later, I'm starting to get more worried that this is schizophrenia, right? If they had psychosis before they had the drugs, I'm starting to get worried that this is schizophrenia, right? So you have to find that period of time where they're not doing drugs, and it has to be a pretty good long time. And then if they have the psychosis or the symptoms outside of that time, in their periods of abstinence, then okay, you probably do have an underlying anxiety disorder. The first thing we need to do is to stop the marijuana because that's not helping anything at all. But you probably do have this, right? In addition, so you probably have 2 things. So let's say a patient is psychotic. This is another example, and they believe that they can speak to their horse. This is a true story. They have a developmental delay and a traumatic brain injury. How are you going to determine what their psychosis is due to? So this is another example. Head injuries can also cause psychosis. How do I know that it's due to a head injury or it's due to like schizophrenia or something else? Well, I just asked them, when did you fall off your horse? Did the voices start after you fell off your horse, or did they start before that? And what you find out is the answer here is that the voices started after they fell off the horse. They present to the emergency department with the ability to speak to their horse. The mother brought them in because the horse, the mother always interrupted her daughter's interactions with the horse. This made the daughter very angry. Can't you see? I'm talking to my horse right now. This makes the patient very angry, and she's almost come to blows with her mother. The labs are normal, the imaging's normal. And she said she gained the ability to speak to her horse when she was 25 years old after she fell off of her horse and hit her head and got knocked out. Since then, she's fallen off her horse 2 other times, which has augmented her abilities further. So she actually, this is kind of a dangerous patient because she became psychotic because she fell off her horse, and now she has this special power to talk to her horse, which she loves. And now she's kind of like putting herself in risky situations to hit her head more, because she's like, I can talk to her even better when I hit my head. So, you know, it's kind of scary. So key points to this case: the auditory hallucination and the belief, which is a delusion, right? That she can actually speak to her horse. You know, delusions are always hard to prove or disprove, but my guess is she can't actually speak to her horse, that her horse isn't actually speaking to her. So I would call that a delusion. Now, could it be schizophrenia? Schizophrenia for women does usually start a little later, in their late 20s. So we definitely have to keep that in the back of our mind. Now, if she was 50 years old or 8 years old, it's probably not schizophrenia, right? Because those are unusual times of onset. In terms of longitudinal history, age of onset is very important. So that's really the key with longitudinal history, is when did this start? And then when do most diseases like that start? And we'll go over the starting of these diseases in a second, because they all have kind of different starting times. No family history, so we always want to know family history. There is a very high rate of serious mental illness. By serious mental illness, I mean schizophrenia, true bipolar 1, and then family members that then suffer from serious mental illness later. So this runs in families. Sometimes it'll skip around. It might be an uncle, it might be someone like that. A lot of the times you only know half of the story. You know, it's a single parent household, and so you might not even know dad's story. That doesn't mean that dad didn't have any mental illness just because you don't know it. The labs are normal. Imaging was normal. Now, we could have thought of other tests, but like seizures, we talked about that. But I mean, in this case, I don't know, the girl fell off her horse and then immediately after gained the ability to talk to her. So the history to me seems pretty clear. So really what we have to talk about now then is, what is the age of onset of these disorders? And this comes from the Synopsis of Psychiatry. This is a big textbook. This is what most psychiatrists use to study for their boards, actually. At the end, it's essentially just the DSM-5 within like Prevalence and other things kind of thrown in there. This is the synopsis of a 2-volume work. So this is like 1,800 pages, and then the 2-volume work, I don't think anyone's ever read that. It's like 3,000 pages or something. So you can just flip through this if you're ever curious. You don't have to be. Or you can just look at this slide. So for depression, men is bimodal. We typically depress in early adulthood because we're like, I don't have a job and I'm a loser. And we come to terms with that. It's like as a teenager, you're just running around and you're like, I don't have a job, that's fun. And then you become an early adult and you're like, oh, I'm a loser, I don't have a job. And then that's not fun, and then you get depressed. And then retirement's kind of the same. Now I don't have a job anymore. My entire life was wrapped up in my job. Now I feel depressed. And typically this is kind of like just the grumpy old white guy. That's typically how it expresses itself, with that kind of irritability element. Women is more cyclical and based on hormones. So that the biggest time in a woman's life will actually be like near menopause, because that's when all their hormones just plummet. And estrogen and progesterone are feel-good hormones. So it kind of sucks when all your feel-good hormones get taken away from you, like right prior to menstruation. and then you know, right at menopause. So that's really common. Schizophrenia, men, early 20s, so anywhere from like 15 to 25 is a typical first break for men, with prodrome symptoms prior to that. Schizophrenia is a neurodevelopmental disease. So it actually begins, if someone asks me when does schizophrenia begin, it actually begins prior to conception. Well, actually at conception, because it makes brain changes even in the womb. Women is late 20s, so anywhere from 25 to 35 is a typical onset of schizophrenia. Bipolar 1, early 30s, typical, both for men and women, so a little later. They're typically functioning well. Maybe they've had a depressive episode, but their first manic episode, typical depression episodes in bipolar 1 is in their 20s, but they won't have their first manic episode typically until early 30s. Now I have seen teens with mania. This does happen, but it's the exception. Anxiety, preteen or teenage years. This is one of the first disorders ever to come out with like social anxiety, generalized anxiety. The very first is actually ADHD, which can begin around like 3 or 4. Borderline personality disorder, usually teens with cutting and chronic suicidal ideation. Kind of another form of chronic depression. That's kind of what I categorize it. So you have this one kind of typical depression that's bimodal for men and more cyclical for women. And then you have this other kind of chronic suicidal ideation, which is kind of more borderline in nature. That finishes our second point. So we're whizzing right through this. So now the next question is, how do we increase our clinical acumen even more by using simple screening tools? But just to summarize what we've just covered, again, medical causes are important causes of mental illness. Second point, we have to explain the pre and post test probability. So this is just prevalence, like I said. What's the likelihood of this depressed person that just walked into my office having a traumatic brain injury, drug use, age is a factor in that, their medical comorbidities are a factor in that, what kind of medical conditions they have. Their gender is a factor in that. In the case of depression, right, we see that different distribution. And then all of this clinical knowledge together is what helps us lead us to the right diagnosis or the right couple of diagnoses. Sometimes we can't narrow this down to one. Sometimes I say, you know, I think we need to figure out this sleep apnea thing first. And then once that settles down, we'll see if you also have an anxiety disorder, just because I can't tell right now. Because the picture is often kind of muddy. And that's okay. It's okay to not know something. So then how to use simple screening tools. This will help us even further. So in psychiatry, we don't have imaging. No imaging is going to give you a diagnosis. But what we do have are screening tools. We have these either subjective or objective. I use objective in quotes because the objective scale is from me. Sometimes I'm objective, sometimes I'm not. And so, you know, well, we have these two types of scales, and I use these for even like learning purposes for patients to kind of help them convince them, like, hey, look, your stop bank score is high. Maybe you should get a sleep study. And, you know, I thought this before. Sometimes patients actually trust the scales more than me, which makes me chuckle to myself. It actually kind of brings me joy because I'm like, the scales were invented by people like doctors like me, but that's okay. It's like trusting the invention, but not the inventor. So that's fine. I'll just use the invention to convince them. And I'll say, look at this cool scale. Oh, it's so good. And then you probably have obstructive sleep apnea. Why don't you try it? So this is what we're going to learn. So what scale is used for sleep apnea? We said that, stop bang. What test is used to screen for borderline personality disorder? That's the Xanarini. What test is used to screen for delirium? It's serial 7s, alert and oriented, and clock draw. And the last one, audit C, of course, is used for alcohol. Some of you may be more familiar with this one probably than some of the others. But we won't just do audit C here. We'll also be doing a NIDA scale. And there's one question that screens 100% of all substance use disorder patients with one question. So we'll learn about that question as well. So this is the stop bank. So what have I been talking? What does that mean? So it was invented by this guy Chung in 2008. in the Journal of Anesthesiology, and then in the British Journal of, I think this is the British Journal of Anesthesiology in 2012. These citations are in my references at the end. Very simple scale. You can just give this to your patients. Do you snore? Yes or no. Do you feel tired? Yes or no. Have you observed to stop breathing during your sleep? Yes or no. So you have to have, typically this is harder with single people or people that don't have partners, because I mean, now I have had some patients say, you know what, I've woke up gasping for breath. Now you have to decide if they had a nightmare at that time or not a nightmare, right? Because that'll make people gasp for breath. But if it's not a nightmare and they're like, I woke up gasping for breath, oh, okay, you know, that's a yes to me. But sometimes spouses will say, and this is rare, this is a more rare question that's yes. If this is yes, they're getting a sleep study. You just don't stop breathing in your sleep and not address that. That's important, because you could die from that, right? You'd have to kind of ask them what their partner thinks. And then, do you or have you been treated for high blood pressure? Is your BMI more than 35? That's very high, right? Obese is 30. So this is higher than obese. Age over 50, neck circumference greater than 16 inches, and are they male? So check this out, Let's say a 50-year-old male that's overweight walks into my office and I notice he has a thick neck. How many patients do you know that are like this? Or like, how many people do you see walking around the street that are like this, right? So, okay, yes, right? We just scored 4. Just knowing that a 50-year-old male walked into my office with a thick neck. 16 inches is, I have a 16 and a half inch neck. So this is not, this is not a large neck size necessarily. Oops. What is their risk? They already have intermediate risk. Anything in intermediate risk and high risk, 3 to 4 points or 5 to 8 points, needs a sleep study. So these patients already need a sleep study. If he has one other thing, you know what, doctor? I feel really tired during the day. Now they're high risk, right? Now he's high risk. So there's just a whole lot of people that are walking around with undiagnosed sleep apnea. And this is a huge epidemic actually in our country that a lot of medical doctors actually don't screen for. This isn't for some reason a common screening tool in primary care. And then a lot of people think that all I do is, as in psychiatry, is try to like mind control them or something, which is not my goal. I'm not actually trying to mind control them. I'm like trying to figure out if they have a really bad sleep apnea most of the time. And so really, this is something that you can really help educate patients on and say, I just learned about the sleep apnea thing. And I just learned how common it is and how common it is for depression. And I wonder if you should talk to your primary care doctor about getting a sleep study, because that might actually be one of the causes of why you're feeling so bad right now. The next scale, so that's the stop bang. So these scales are very simple, right? You just score it, yes or no questions, and you add a total score. It risk stratifies them. If they're intermediate or high, they need the test to rule out that disorder. And in the case of sleep apnea, it's a sleep study. We'll go over that. We're going to talk about all of these. So these 4 conditions: sleep apnea, delirium, substance use, and traumatic brain injuries, that's the subject of our next hour. I just couldn't decide, kind of a chicken and the egg thing. Do I talk about those first and then do this? I just did the scales first just to show you how easy it is. You don't even have to know anything about these disorders to screen for them. You can just screen for them yourself. Borderline personality disorder. And I notice, I think there's a chat here. Oh, yes. Yes, we will talk more about it. Someone in the audience just had sleep apnea. And so, this is really common, and we as we don't, a lot of people don't know about this. So the Zanarini scale. So this scale is really funny to me because essentially what they did was they just took the DSM-5, all the criteria of the DSM-5, all 9 criteria, but then they made 10. They kind of split one of the criteria, and then they just turned them into yes or no questions. So it's like, you could also just read them the DSM and say like, do you have this? Yes or no? And then that's the Zanarini scale. So have a lot of your closest relationships been troubled by a lot of arguments or repeated breakups? Yes or no? And this is, again, another didactic thing. So it's hard to convince people of these kind of personality disorders because they feel so subjectively awful. And then they think like something awful might happen. So kind of the way I do this is I counsel them and I say, you know, borderline personality disorder is really awful, right? It's really, I would imagine it's a very awful subjective experience. And I can imagine this because there's times when I've split in my life, right? There's times when I'm like, I know you, Dustin, I love you, but you're in the bad box right now, right? And that just feels horrible, right? Because I know Dustin as a person, I enjoy him. And it's really hard to do that, right? And so there's times when we all have these kinds of things, paranoia about people, thinking that people are going to leave me, right? If you've ever been in a breakup before, you've probably felt that. So you can really have a lot of empathy for people with borderline personality disorder. And so that's what I say is this is a horrible disorder, but it's very treatable. And I want to figure out kind of what's going on here. So have a lot of your closest relationships or trouble arguments or repeated breakups? Yes or no? Have you deliberately hurt yourself, punched yourself, burned yourself? How about made a suicide attempt? Now this is interesting because it's kind of static. So, you know, if they cut themselves at 13 years old and they never cut themselves again, it's still kind of scored as yes. Same with like a suicide attempt, right? Now they're in their 50s and they haven't done it for like 40 years. It's still a yes. So, but it's in the DSM. Have you had at least 2 other problems with impulsivity, eating binges, spending sprees, drinking too much, right? Bulimia is very comorbid with borderline personality disorder. So if you're worried about borderline personality disorder, you're looking at bulimia as well. Have you been extremely moody? Sounds like me when I'm arguing with my wife. Have you felt very angry a lot of the time? How about often in a sarcastic manner? Have you often been distrustful of other people? Have you felt unreal, right? So we've probably all felt this to some degree. Have you chronically felt empty? Have you felt like no idea of who you are? You have no identity? Have you made desperate attempts to avoid feeling abandoned? And I love this that they give an example, like repeatedly called someone to reassure yourself that he or she still cared, begging them not to leave you or clinging to them physically. This is the one where they'll just say yes, like, oh, that's me. And they always feel some level of shame about this. So I always, whenever they answer yes to this question, I always try to encourage them to, because there is a lot of shame wrapped up in this as well, which just isn't necessary. It is a, and you know, there's different theories for borderline personality disorder, but it is a way of dealing with the world when all other methods have failed. And so in that way, I think it should be respected, right? Now the funny thing is this is straight out of the DSM, and now a score of 8 or more is indicative of a diagnosis of borderline personality disorder. And that's a lot because in the DSM, it's 5 of 9 criteria. So it's kind of funny that the threshold for the screening tool is so much higher for the Xanarini. So typically what I'll say is if they're in the 5 or 6 kind of camp of the Xanarini, I'll say, you know, you didn't get a positive score, but just like learn about it and, you know, tell me if this fits you over your whole life, right? Because as a personality disorder, this can't just be this moment of time. Because, you know, if a terrible tragedy happened to me right now, I would answer yes, probably to all of these questions, right? So that doesn't count. It's a pervasive pattern, like all personality disorders, over the course of your life, right? You know, I'd ask them that, and then I'd say, you know, this is just from the DSM. So you kind of are meeting criteria, but it's not positive on this. And we'd have a dialogue basically about it. And I'd really be curious too, what it meant to them. What does this new possible diagnosis mean to them? And what kind of meaning are they forming out of it? That's something I would also be really curious about. And, you know, it says here, a pervasive pattern of instability of interpersonal relationships, self-impact marked by impulsivity. That impulsivity is really a really good screening question too. My screening question for borderline personality disorder is, do you get really moody? Do you just like fly off the handle at a moment's notice? That screening question, I don't have the article here, but it's typically about like 80–90% sensitive. So a lot of people with bipolar disorder and these rapid cycling, where they're cycling throughout the day, is really just mood lability. And it's more of kind of a personality aspect than like a bipolar disorder per se. So that is borderline personality disorder and the Xanarini. You just yes or no questions. Next would be neurocognitive screen. This maps onto delirium. So this is, how do I know if it's delirium or not? You ask them alert and oriented questions. You ask them to draw a clock. You ask them to remember 3 words, and then in 3 minutes, test them on it. And you ask them to count down by 7 from 100. So what are my alert and oriented questions? So if I'm in the hospital, right, like I said, in the ICU, delirium is the biggest thing. So if I'm in the hospital, I basically walk in the room. We talk a little bit, and then I say, where are we right now? You know, I need to ask you just some questions before we even talk further, because this is what I say, because a lot of patients in the hospital are confused. And so my biggest issue is to find out if you're confused or not. And so I just need to ask you a couple questions first. Where are we right now? What city are we in? What is today's year? And saying typically when they get the year wrong, they'll say like 2021, or they'll be like 2001. If they're going back and forth between 2001 and 2021, they don't know the date, right? Because the year kind of stays the same for a year. So that's a long time. So, you know, on a typical day, I at least know the year. So, you know, they're already not oriented. Now, the reason why I ask these questions first, like, how did you get here, is if they can't answer these questions, there's really not much of a point to getting a full history from them. You know, they might know some biographical data about their life, but it's all kind of suspect at this point, because they think the year is 2001, right? And they think they came to the hospital because they're a sailor, they're here for a job interview, right? These are stories that people have told me. So I'm not going to ask them like, have you ever seen a psychiatrist before, when they're in the hospital and they think they're on a ship, right? Because that's probably, I just don't know if I can trust it or not. So then I need to call their family, right? Is really what I have to do. But one thing I can do is do some of these other studies to check in. Now I know they're not oriented. What am I going to do next? Next, I'm going to say, why don't you try to draw a clock? And this is exactly how I say it. I say, why don't you first draw a circle? And the first thing I do is I just see how well can they draw a circle. Now look at this circle. Why don't you draw a circle? So I really try to take this piecemeal. Now, if this is their circle, we're already going to have problems, right? It's going to go downhill from here, because you can't even close a circle. And I've seen, you know, and you can also see while they're drawing the circle how fast the circle is. Are they just like not taking their time? Is there any thought, like, look at them when they're doing this. Is there any planning in their mind at all? Because if they're planning this out, then they're using the front of their brain. If they're not planning this out, then they're not using the front of their brain. And that's a problem, right? And it shouldn't take too much planning and thought to draw a circle. If they're maxing out their intellectual capacities drawing a circle, then there's already a minor impairment there, right? So even if they draw this perfect circle, but man, they're just sweating bullets drawing the circle, I'm already kind of like, uh-oh, you know, that's not a good sign. So draw a circle. Okay, now put in the numbers. Now, when I put in the numbers, I'm also thinking, is there any planning here? 12, 6, 3, 9. That would be a nice way to draw the clock, right? And then putting the 1 and 2 in, and then the 4 and the 5, so that the spacing is nice. Or are they just going around like this person? 12, 1, 2, uh-oh, I have to get 6, 3, 4, 5, 6. I did it, because the 6 is kind of lined up. Now I have to get back 7, 8, 9, 10. Oops, I need the 11 over here, right? So again, this is a problem in planning. And then the hands are the hands. I tell them to set the clock to 10 minutes past 11. So is there a shorthand and a longhand? And like in this case, there's a shorthand and a longhand. And I hope this person said to set it to 2:55, which I doubt, since most of us say to set the clock to 11:10. This person had the shorthand pointing in the wrong direction, which is very common when you're not thinking straight. So they just reverse it in their mind. So this is, again, the spacing's bad, the hands are bad. And this is late dementia. I've seen it this way, even later dementia, these numbers will just turn into like symbols that are not even recognizable, like dashes or things like that. So this is just a general test to see how well their front of the brain is functioning. It doesn't tell you whether they have dementia or not. It just says, how well is your brain functioning right now? How are you concentrating? And if I get a clock from this person, again, I'm not going to get history from them. They're not going to give me any good data. This person, I might get a little from them, depending on if they know what the year it is. So I'm asking the question, can I get history from this person or not? Or do I need to turn somewhere else? Now I want you to remember 3 words. This is what I tell the patients. Church daisy in red. I start a timer because I cannot keep track of 3 minutes in my mind. Typically I say this first and then I have them draw the clock. So I'll say, you know, where are we? What's today's date? What's your name? And then how did you get here? And then after that, I say, all right, I want you to remember 3 words. The words are church, daisy, and red. These are just the words from the MoCA, the Montreal Cognitive Assessment. You could pick any 3 words you want. You just want them to be kind of different, right? Nouns are always typically a little better. And then I just set my timer for 3 or 5 minutes or however long. Now this isn't an immediate recall. So some people will say church daisy red, and the patient will be like, what? And then you're like, I'm not going to say them again. I'll tell you again in 5 minutes, and I'll ask you, and they're like, I don't even know them. So I will repeat this as many times as possible. If I have to repeat this 20 times, I'll repeat this 20 times. I do not care. Because it's not an immediate recall, it's can you keep that in there while we're doing something else? It's a delayed recall test. So church, daisy, red. Tell me those 3. Church, daisy, red. And then they'll say it. Sometimes I'll have them repeat it, even if they say it the first time really well, I'll have them repeat it 2 or 3 times. I want to give them the best possible chance they have. I set the timer and then I ask them. And like the MoCA, you can do category cues. So you could say, one of them was a shape or a color, excuse me. I was looking at this. One of them was a color. And then if they can't get red, then that's not super good because that means they literally didn't contain it all. One of them was a flower. One of them was a building. And then if they can't get that, one of them was a color. Was the color red, blue, or white? And then you can give them multiple choice, and that gives you a more nuanced view of how impaired they are, right? If they can't even get multiple choice, then you're like, oh no, that's not super great where they're at right now. If they can get it very quickly, right? Once you give them a category clue, it was a color, oh, it's red, right? That person's doing much better than if they couldn't remember it at all. So you can get nuanced in this as well. The first thing to go in Alzheimer's and pure Alzheimer's is they will get 2 out of 3 in delayed recall. Everything else will be normal, but they'll get 2 out of 3 on this, and that's a hint that maybe something like that's going on here. Also, if they have delirium, they won't be able to do this because their concentration is just shot. They can't concentrate for anything. Serial 7s, this is an attention or concentration test. So this is not a math problem. So in medical school, I did this wrong because I told a patient, all right, let's start from 100 and go down by 7. And then they said 93. And I was like, perfect, 93. We got 93, 93, 93. And I was saying it, what's the next one? And they're like, 93, 93. And I'm like, yeah, 93. And so it's not like, I'm not trying to help them subtract here. The problem is that in order to do this, they have to say, what's my task? My task is to -7 from 100, okay? All right, I -7, it's 93. Now I have 93. Wait, why do I have 93? What's my task again? My task is to -7. Oh, okay, 7 minus 93. Wait, why am I doing this again? This is kind of how we all think, right? And then you -7 from 93 and you're like, oh, okay, 86. Now, let's say they said 85. It's not a math test. So I say, keep going. If their next number is 78, they're still doing the task, right? Now they might have some impairment, but they're still doing tasks. So actually, and this is straight from the MoCA too, if you look at the MoCA, if let's say they said, and this is, I guess, what I would say when I was old and demented and someone was like, do your serial 7s, I'd be like 0, -7, -14, -21. That's 2 out of 3 points on the MoCA because I didn't attend to the task, but then I was able to attend by correctly subtracting the next numbers. And I'll just have them go a little bit and then they'll do this. Now see their cadence and how fast they do it. That's another part. So I just had a patient and the only thing that let me know that they were delirious was they said 193, 85, 78. just like that fast. And it even took me a second, but like, look, they didn't think before they did something. And this was kind of the entire interview, right? They were just distracted. They were going off all these rabbit holes. Their attention was impaired. I could probably figure it out even without doing this task. So this task isn't necessary, and you can modify it as you need to. So you could, let's say some patients don't know math. If you don't know math, you can do days of the week backward. You can do months backward. So starting from December, why don't you tell me the months of the year backward? And then they're like, wait, what? Starting from December, why don't you tell me the months of the year backward? December, November. Now don't step in, right? You just want them to keep going. November, October, September, right? And then if they can't do that, then I know they already have an attention deficit. I'll ask them, I'll say, all right, do days of the week backward. And if they can't do that, then I'm like, okay, this is really bad, So there's a way to kind of measure severity in this, because if you can't even do the days of the week backward, that doesn't take a lot of attention. Their attention is very impaired. So that is how we're going to screen for delirium, and also just orientation, and also just kind of knowing what's going on here in the world. Now, how do we screen for substance use? Super simple. Here's an article that was published in 2010 from the Archives of Internal Medicine. And it's all here in the abstract. We don't have to read the article. How many times in the past year have you used an illegal drug or a prescription medication for non-medical reasons? A response of at least one time was considered positive. So you say, you use this question, how many times in the past year have you used an illegal drug or prescription medication for non-medical purposes? I have. 100% sensitivity. Now, there'll be people in there that are not substance users, but you will catch all substance users with that one question. So no substance user will slip through your grasp if they've answered this question yes. Now you just have to eliminate all the people that aren't substance users, right? That's all you have to do now. So with that one question you have, now, I changed this in my own practice because people don't consider marijuana an illegal drug anymore, right? They're like, oh no, I don't do anything illegal. I just smoke a bowl a day, right? And you're like, cool. So do you do marijuana? Typically what I'll say is, do you smoke? Because that gets both tobacco and marijuana. So my questions are, how many times in the past year have you used an illegal drug or a prescription medication for non-medical reasons? Never. Okay, perfect. But my screen's not done. I say, okay, do you smoke? And that's ambiguous enough where it could be marijuana or tobacco, right? And they're like, I don't do weed. Oh, okay, perfect. You don't smoke weed. Do you eat it? Do you vape it? Just to double check. And then do you smoke any tobacco products or do any tobacco products? And then do you drink? Because drinking isn't illegal, right? And drinking isn't prescribed. I've never prescribed anyone, why don't you go home and just drink a bottle of vodka? So, those are the other questions you have to ask. This is the audit C. I don't really need to go over this. This is just a simple screener for alcohol. And it says, I guess I am. How often do you have a drink containing alcohol? How many standard drinks of alcohol do you do? And then how often do you have 6 or more drinks? But this screen is better. That's why I don't really care about the audit C, the NIDA screen. This is all the questions that we just asked. So this is something you can give your patients even before you see them. Now you don't even have to ask these questions. Prescription drugs for non-medical reasons, illegal drugs, tobacco products, alcohol. For men, a positive screen is anything more than 5 drinks a day, 5 standard drinks. And they have that defined in this handout too, if you just Google it. Or for women, 4 or more drinks a day. A positive screen for at-risk drinking 2 for men, other than 5 drinks a day, is a drink every day, 2 drinks a day, so 14 drinks in a week. And for women, 1 drink a day, so 7 drinks a week, would also be a positive screen. Another way to double check on their alcohol use. And with alcohol use, they'll often minimize. Minimization is one of the prized defenses in any use disorder. And so you definitely have to clarify the quantity, because I only drink 1. Okay, like what's 1? And I always just do a little bit overestimate, like a nice tall glass of whiskey. Oh yeah, I just have 1 nice tall glass of whiskey a night. Oh, okay. And how long does the bottle last you? Oh, the bottle of whiskey, it'll last me like 3 or 4 days. I'm making it last a lot longer now than it's been in the, in the past. And you're like, oh, okay. Now, is that bottle like a 1.75 liter bottle or a 750 milliliter bottle? Oh, I am making it last longer, but it is a 1.75 milliliter bottle now. And it's not a 750 milliliter bottle. So their consumption has actually gone up, right? And this is a very, very common conversation that I have with people with substance use because of that defensive minimization. And you just go along with that defense and you just say, oh, okay, like, so you do this, and you just overestimate a little bit. Just 1 bowl a day of marijuana, not 2, not a little bit of vaping in addition to that, just a little bit, and that's how you're going to get more information. So this is a summary then of this hour, obstructive sleep, of the screening scales. Oh, I should have included this. Oh yeah, no, we just did this. So stop bang for obstructive sleep apnea, Xanarini. Neurocognitive disorders like delirium, like dementias, attention, orientation, delayed recall, clock draw, attention tasks being those days of the week backwards or serial 7s, and then substance use, that NIDA assist I really do like. So let's do the post-test questions. Hopefully these are now really easy, especially since we've already gone over the answers, and because hopefully we paid attention. The DSM-5 states that the medical illness supersedes mental illness. This is true. 50-year-old male with obesity, hypertension, insomnia presents with new onset anxiety. He may have a primary mental illness, right? Because he has all these, 50-year-old male, he has obesity, hypertension, that's 3 on the stop bang. I know that now. That's intermediate risk. 50-year-old male has new onset suicidal thoughts with plan, and he is post-op day 5. He was just in the hospital. He just got cut into. This is delirium until proven otherwise. A 22-year-old medical student presents with psychosis. He has ADHD. He's misusing substances. He's using prescription medications that weren't prescribed to him. We just learned that that is a positive screen for substance use, right? So he just screened positive for substance use. So we need to make sure that it's not that. 60-year-old male with morning headaches, snoring, hypertension, presents with subacute depression. His stop bang scale was scored as high risk. So this is, this guy's off the charts. Definitely sleep apnea. What scale is used for sleep apnea? Hopefully we've burned this into your brain, the stop bang. Borderline personality disorder, Xanarini, delirium, serial 7s, alert and oriented, clock draw. And now we're on to our last objective. So thank you for your attention during this hopefully hour. I tried to keep it in an hour, and we'll move into the next hour. All right, so we finished our first hour and we talked about a lot of disorders. This hour is basically just to kind of submit thinking about these 4 disorders that we've already touched on and kind of learning what they are. You can recognize a zebra. So what we talked about is basically recognizing the zebra, right? Or recognizing the horse. And you can do that without actually knowing what a horse is, right? I have no idea where the heart is in the horse, where the lungs are, right? I have no idea how long the average horse's leg is and things like that. But so that's kind of the goal in this part, is like, what is this thing that we've been talking about, sleep apnea? Because now you can recognize it, but you just might not have a conception of what it actually is. And so that might be helpful to kind of learn about. And so we'll go through each of these 4 conditions: sleep apnea, traumatic brain injury, substance use, and then delirium. So we'll start with obstructive sleep apnea. Oh, so this picture is what obstructive sleep apnea is. So it's in its name. There's an obstruction during sleep. Apnea just means you stop breathing. An apneic episode is anyone that just stops breathing. So you're sleeping and your throat, it's kind of your throat. It's really more of your air pipe, right? Your air pipe closes, and that's a problem. The prevalence, very prevalent, 9 to 38% of the general population. And really, I went over the stop bang and all of the screening, but there are thin people with thin necks that are young that have sleep apnea, that don't snore. So this is just really prevalent, and it's in a lot of different types of people. And just because you don't have the risk factors doesn't mean you don't have it. So it's just something to be aware of. It's of course more prevalent if the BMI is greater than 30. It's 40% prevalent. Serious mental illness, 26%. Depression, a little more than 1 in 3. Bipolar 1 in 4. And schizophrenia, even 16%. Right? Schizophrenics tend to have a poor diet. They tend to not take care of themselves. And then the medications that we add often make them gain a little bit of weight as well. And so these would be some of the reasons why schizophrenics also have sleep apnea, and why it's comorbid with it. So you can have schizophrenia and sleep apnea. So you can also have both of this. And I would also say there's family history involved in sleep apnea as well. And if they have a positive family history, it's just worth getting it, because you can really change people's lives by getting this study. Also, we miss it. So in one study, there was, in this McCall 2019 study, there's 125 suicidal patients. And the PIs of the study, none of them, and these again are doctors, none of them suspected them of having sleep apnea. And when they tested for it, 14% of them had it. And the suicidality could literally just be due to, and their depression could just be due to, the sleep apnea. And they were lumping all of these sleep apnea people in the study together with these other people that just had MDD, right? So these are two distinct patient populations, and now this is going to mess up the study. It's going to skew the results. And I have a feeling that there are actually a lot of studies out here where this is the case, where we have multiple different patient populations and we all call it the same thing, but it's actually 2 or 3 or 4 different patient populations. And they're suffering from 4 different things, but they all have the same kind of endpoint, depression. And so we say it's all just depression. So this is a real problem in psychiatry in general too, is that a lot of the disorders, even like schizophrenia, it's heterogeneous. There's not really one thing that's schizophrenia. It's like 100 things, but they all have the same result. And we call that result schizophrenia, kind of like shortness of breath, right? But shortness of breath is a result, but it could be caused by pneumonia. It could be caused by COVID. It could be caused by common cold, right? And so this is kind of the most difficult part in psychiatry, is trying to figure out the root cause. Why is sleep apnea important? Well, if you have sleep apnea and you don't know it, you have 20 times higher risk of post-operative complications for basically any surgery. And that's if your stop bang is just 3. So this isn't even like diagnosed sleep apnea. This is like just if the screener is low intermediate risk, you have a 20 times higher chance of having a post-operative complication. So it makes me wonder, some people that we've known have had post-operative complications. Did they have sleep apnea too? Was that playing a role in this? Sexual dysfunction. This typically is a motivating factor for patients. You say you're depressed and you say you have no sexual desire and you want that to change. It could be due to the depression, or it could be due to your sleep apnea. When I don't sleep well, and when I can't get air, I feel like not doing a whole lot of things, right? When I don't get air and when my airway closes. The biggest, of course, is increased mortality. There's after using their CPAP, which we'll show a picture of that in a second, but this is the treatment for sleep apnea. It reduces mortality by 40%. They're like, there's a lot more people that are still alive if they just use their CPAP. And patients will tell me all sorts of things. I can't use it, it's just too uncomfortable. And really, it's like their life is on the line. And this is after 5 years. 5 years is not a long time, right? What happens after 10 years? What happens after 15 years? What happens after 20 years? And so this is just the single greatest thing that I can do for patients, and this is why. OSA risk factors, we've already gone over those, the stop bang criteria. And then these are questions that I just think about. Do they have a thick neck? What's the spacing of their mouth? Do they have a big tongue? Sometimes I'll ask them to stick out their tongue. Do they have hypertension? These are more of the questions. So these are more objective findings that I look for: thick neck, large tongue, hypertension. These are things that I ask every patient. Do you snore? Do you have headaches in the morning? Do you get super tired during the day? Will you even fall asleep like almost while you're doing day-to-day tasks like driving? Or do you fall asleep just watching TV? You know, I mean, there's reasons why people will do this. Like you could just have had a baby. I mean, that's a good reason, you know. But if it's happening kind of pervasively, then you need to think about it. And then do you have any family history? Does anyone in your family have sleep apnea, or has anyone in your family used a breathing machine, is what I call it. Anatomy is really the biggest risk factor. So you can see in this picture, this is a non-apneic individual. You can see their airway. So from the nose down the windpipe right here, you can see a nice dark space. This is all just empty space for the air to travel. This patient, their tongue is pushed back. So it doesn't even necessarily have to be a big tongue. It could just be their jaw is pushed back a little more. Like they just have, this is, you know, this is the way they just look. Some people just look that way, right? And so then all of that being kind of crammed back anatomically is just gonna shut down their windpipe. And then when they relax, when they sleep, it's gonna get shut down even more. So these people can breathe during the day, but then when all their tongue relaxes and slides to the back of their throat at night, and all of the surrounding musculature relaxes, their airway is just going to shut. And that's the biggest risk factor, is really just the anatomy. What happens when your airway shuts at night? Well, basically you get this repeated cycle, and this is kind of how I try to explain. I'm trying to figure out a better way because most patients still don't understand it when I explain it. So I'm trying to figure out a better way. But basically you start out in shallow sleep, right? Very light sleep. And then when you go into deeper sleep, everything relaxes. Your airway relaxes. And when it relaxes, your airway closes. When your airway closes, I don't get into this, but you have a sympathetic surge. And you're basically like, right? And then your airway opens because you come out of that deep sleep and you come into lighter sleep now. Basically, I'm not breathing. Your brain is like, I'm not breathing, I'm not breathing, I'm not breathing. Come back into lighter sleep. Your airway opens back up because now your airway is not as relaxed. And then basically you just do this throughout the entire night. And people with sleep apnea can do this 60 times an hour. I've seen it even more. 60 times an hour. They're not breathing, they're going into deep sleep, they're going back up, and they're getting a burst of epinephrine, a burst of adrenaline every time. So it's just really bad for your cardiovascular system, because you're kind of exercising during your sleep. And it's also really bad because sleep is kind of important. If you don't sleep, you die. And they're not getting deep restorative sleep. They're always staying in that shallow plane of sleep. So they're just not going deep. So I kind of think about this like as a water, right? You really want to dive deep into sleep. And they're always kind of hanging out at the surface here, right? They're not able to get on their scuba gear and go deep just because their airways closing. This is what it does to the sleep architecture. So this is kind of a pictorial form of seeing how they don't go deep into sleep. You have 5 stages of sleep. REM sleep, which is your dream sleep. It's the lightest. Stage 1, 2, 3, and 4. This could be a whole topic of another hour lecture. It's just really interesting. And what happens at each of the stages and everything like that. But basically, early in the night, notice you spend most of your time in stage 4 here, especially in that first 90 minutes. So you typically go straight into this really nice restorative sleep. And then at the 90-minute mark, you have your first dream sleep. And then you stay there for just a little bit. And then what happens is over the night, your deep restorative sleep gets narrower, because this is the most important part that your brain wants first. And then your REM sleep gets longer. So you can see you're spending more time in REM at the end of the night and more time in deep sleep at the beginning of the night. And so this is why we often wake up in the morning in like a dream state, because our body's like, oh, I'm ready to get up, right? And this is why sometimes when patients have like early morning awakenings and they're like, man, I'm waking up for like 10 minutes. It's horrible, doc. And I'm like, what time does that happen? It's always like 2 or 3 a.m. I'm like, well, you've already gotten the bulk of your good sleep. This is actually, you're probably in REM. That's probably why you're waking up. And you're going right back into sleep. It's not a big deal at all, because you're kind of right below the surface of the water, so to speak, anyways, right? And now you can see this is of an elderly patient, so we have a lot to look forward to as we get older. You basically can't get any restorative sleep as you get older. Stage 4 goes by, stage 3, you get like 10 minutes here. And then you're just cruising in stage 2. But this is basically what it would look like for sleep apnea too, right? Because when you go from stage 2 to stage 3, your throat's relaxing, and then you're like, oh no, I'm not breathing, and then you're just going to go right back up to the surface, right? And then your body's going to try to dive down, but it can't, because every time it's diving down, it's relaxing, and so you're going to end up with this really fragmented sleep. Notice, because your body needs to get stage 4 first, so it's trying to go as deep as it can, and then it just can't. So not only are you not getting the deep sleep in this, you're also not really getting your REM sleep either. So it's just a horrible, horrible quality night of sleep. You're neither getting the deep sleep that you need, and you're also not getting the REM sleep. And so then all you have to do to restore this is just use a sleep machine. This is another way of looking at the pathophysiology. We've talked about the anatomy. This is the effects. Really, this is the effects of sleep apnea. So what does it do? And this is just in a nutshell. Basically, my brain doesn't have oxygen, which causes my adrenaline to go off, which causes all the hormonal axes to mess up, which causes psychiatric symptoms because now all my hormones are messed up. It also will lead to more obesity. So typically these are larger patients, not necessarily, but they are typically, which leads to more cardiovascular disease and more diabetes. So now you're in this cycle where like you have a large neck already, and the sleep apnea is giving you a larger neck, and it's making your diabetes even more uncontrolled, and it's giving you a higher risk of strokes and heart attacks. So it's taking an at-risk person and pushing them even to more risk. And then psychiatric medicines try to intervene here, but they really can't, because the problem is your brain's not getting oxygen, right? And so that's what I tell patients too, is I'm going to give you a medicine because you're depressed, but honestly, it's not going to do anything. Because if you have untreated sleep apnea, you need oxygen in your brain. Like that's what you need. Your brain needs oxygen. Let me see, there might have just been a comment. There it is, cool. So how do we diagnose it? So there's 2 ways to diagnose it. Mostly I have patients do it outpatient. So I order an outpatient sleep study, and basically a machine just gets delivered to their house, and then they put on the mask in the machine, and all the results get uploaded onto line. They send that machine back, and then the results get basically sent to them. So they never even have to leave their home. There's certain specific circumstances, like if they have heart failure, if they have really bad COPD, these are patients that you don't want to stop breathing because they already have a huge oxygen debt. And so then you have to send them to the lab. Also, some insurance carriers will make it difficult, as insurance like to do. In this case, it doesn't make any sense to me, because if I was an insurance carrier, I would want to know if my patient had sleep apnea, because I'm saving their life and I'm saving a ton of medical bills. But for some reason, sometimes the insurance carriers will say, no, you can't do that easy at-home sleep study. You have to go into a lab and waste an entire night there. And then the patient's like, I'm not going to do it. And I'm like, no, please do it. So sometimes that happens too. Now, if you go into the lab, it is more intensive. You do have to spend pretty much the whole night there. They put all these electrodes up to you. They take like muscle tone. They check your breathing. They check your oxygenation. So I can say really cool things when I get the report back that patients really understand. So I'll be like, okay, normal people have oxygen saturation of like 99%. Let's look at your sleep study. Oh, look at this. During your sleep study, it went down to 82%. So it's like, that's bad. And most patients understand that they should never go below like 96% oxygenation, and that 82% is bad. And I'm like, yeah, so most nights your brain is getting 82% oxygen. And they're like, oh, and this is even before I go over any of the other findings that make it even more abundantly clear. Like, you stop breathing 60 times an hour. That's bad, right? And they're like, oh my gosh. And a lot of doctors actually don't even go over this with patients, I've found. So this is something that I go over with every single one of my patients. I'll be like, you have sleep apnea. Has anyone ever gone over the study with you? And they're like, I know. And then I'm like, all right, let's go over it. And I'm like, oh, look at this. Oh, look at this. And their eyes will get big. And they're like, I wish someone told me this. I'll start using my mask. And this is a pretty easy way I found with just like psychoeducation to get pretty good compliance out of it. The other big barrier with sleep apnea is a lot of people just don't like the way the masks feel. But the newer masks have gotten better and better. I probably have a picture of a mask here on the next. So this is like a newer mask. So this is a nose mask. Now, there's two types of breathers. There's mouth breathers and nose breathers. So this wouldn't work for a patient that breathes through their mouth at night, but for patients that solely, and this is found out through the sleep study. The sleep study will give you this information. But through a nose breather, this is a really easy way, and they just pressurize the nose. So you're just putting pressure into the nose. It's not uncomfortable because you're just pressurizing the whole tube. And then when you breathe in, more pressure gets pushed in. So the machine knows your pattern of breathing, and it will actually adjust the pressure depending on what you're doing. Now that's really, there's two types. I kind of actually just, let me back up a second. I kind of missaid it. There's something called a BiPAP. A BiPAP stands for bidirectional. So it's helping you with both inhalation and exhalation. CPAP is called CPAP because it's continuous pressure. So it mostly keeps it at like 8 to 10 millimeters of water of pressure. But the machines will also know when you're breathing. So usually it just keeps it like at the same pressure. And usually it's pretty comfortable. If it's uncomfortable, a question I often ask too is, okay, you use your CPAP. How often does it fall off at night though? Because every patient will say they use it, but they're really just using it for like 2 hours and then they rip it off because they're like, I hate this thing. So that's another question that I often ask is, oh yeah, how many times does it fall off at night though? Because then it's like, it's not on them. They're not like the one that's doing it. And then they'll just tell me, oh yeah, I hate it. And I say, oh, you need to go to your sleep doctor. Now, there's other treatments. Patients, the reason why I mention this is because patients will tell you about these. They're like, I don't need my CPAP. I put this oral like mouth guard in my mouth, and it works. It pulls forward the tongue. So it kind of keeps everything forward, the jaw forward, the mouth forward, so it prevents the airway from closing more. It's only 20% effective at best, though. So let's say you're not breathing 60 times in an hour. Now you're not breathing 40 times in an hour. Let's say, you know, your oxygen saturation is going down to 82%. Now your oxygen saturation is only going down to 88%, right? Still really bad. Your brain's still not getting oxygen. Now there's surgical options. These are more last resorts. This UPP, you basically remove all the tissue in the neck, very invasive. So you're removing your uvula, you know, the dangly thing. You're removing the back tissue in the neck to try to open that airway up. Maxillomandibular surgery. In this surgery, you break the mandible right here and you move it forward. Very invasive. The only other thing and these are only 40 to 50% effective. So even if I scrape away all the tissue in the back of your neck, it's only like 40 to 50% effective, maybe. Maxillomandibular is same. This is not 100% effective. The only other 100% effective treatment other than the CPAP is a tracheostomy. I put a hole right here, right? So yeah, putting a hole right here is 100% effective. The other thing that's 100% effective is putting a mask on that pressurizes the whole airway system. And so there are some patients, actually, I just had a patient that I did recommend this. It was the first time. He just can't tolerate a mask. He's severely developmentally delayed, very obese. He's on his 3rd kidney transplant, very sick patient. And I floated the idea. Fortunately, his other primary doctor actually floated the idea before, so it wasn't like the first conversation that I had. But typically it's just me trying to convince patients. Now, if I kind of want to put a little fear into them, I'll say, you know, you could get surgery. You could get a hole right here. I mean, do you want to do that instead? It is. And honestly, the crazy thing is medically getting a hole right here is better for you. You just saw the mortality, right? There's a lot of mortality that's associated with this. There's a lot of morbidity that's associated with this. So it's like, do you want to get a hole here or do you want to get a heart attack? Do you want to get a hole here or do you want to get a stroke and get paralyzed for the rest of your life? You know, I mean, that's really kind of what we're dealing with here. So it is a big deal. So that's really all I have for sleep apnea. So now we'll kind of follow the same kind of rubric through to the other disorders. So the next one is traumatic brain injury. I just saw this new thing on Disney Plus called Stuntman. I don't know if anyone here has seen it yet. If you want to see traumatic brain injuries, you just watch Stuntman. And basically, they use the same screening question that I use. Have you ever got your bell rung? And he says it throughout, like, oh, I just got my bell rung. Just got my bell rung a little bit. Oh no, that's a TBI. Oh no, that's another TBI. Oh my gosh, that's another TBI. Because TBI is basically, you know, I think what most people think when they think of TBI is you just got slammed in the head with this wall here or with a hammer. But that's not really like the heart of what a TBI is. The heart of what a TBI is the brain moving back and forth in the cranium, just ripping all the long nerves that go from your brainstem to your cortex. So that shearing force, that force of those wires going like this from your brainstem, which is where all your neurotransmitters are created. All your neurotransmitters are created in your brainstem. Then they go to the regions they need. All of those nerves are being sliced at their axons. That's really what a TBI is. Now, can it also happen from these coup forces, meaning this person got hit right here in the front and then the brain reverberates and now he also got hit in the back? Yeah, it's from that too. But more importantly, it's due to the single nerve fibers just getting broken from the reverberation, from the shaking. Right, and we can all kind of understand this, right? When an automobile stops, does that mean the passenger stops? No, the passenger keeps going. Does that mean the passenger stops even if they're in a seatbelt and they're contained? No, right? You can get whiplash, right? So it's kind of like a whiplash of the axons. That's kind of what's happening. Why is this important? Well, it's actually the single most common cause of disability and death in the child and adolescent population. So as a parent, what am I worried about more than anything for my kids? I am worried that they're gonna hit their head. I even bought my kid this little owl hat. He hated it, but owl hat when he was like 6 months. And it was basically just like a foam hat. And my wife she laughed at me. And he never wore it. But I mean, that's how like kind of worried I am. And if you talk to most people in my program, this is what we're all worried about. Because, you know, I consider myself a well-adjusted, smart person. But if I get in a car accident, my whole personality could change. It could change at a moment. And that's something that's in the back of my mind. Because I'm not going to die of a heart attack right now. I'm in my 30s, right? I'm not going to die of a stroke right now. I'm going to die in a car accident, or I'm going to get in a car accident and my brain's going to go back and forth and all those nerves are going to shear and I'm going to end up super aggressive like Phineas Gage, right? The prototypical, when we figured out that TBIs existed, right? It took a railroad spike being driven through someone's head accidentally, and he was a well-mannered church-going man. He turned into a drunkard, as he would have said as a churchgoer, a fornicator, all because of a traumatic brain injury. So this radically changes your personality, and it's associated with psychiatric disorders as well. Large portion of the population, 1% of the U.S. population, has long-term disability from TBI. 1.7 million TBIs in the US per year, 1 every 7 seconds, which makes sense, right? Because there's car accidents pretty frequently. It's a chronic cause of debilitating medical conditions, seizures, chronic headaches, pseudobulbar affect. Pseudobulbar affect is intense laughing and crying spells. They can't control them. This will happen after strokes as well. They'll just start laughing and you're like, is anything funny? They're like, no, I just can't control it. And it's actually very embarrassing because you just don't want to be in a conversation with someone and break into uproarious laughter when nothing's happening, or start crying huge, like weeping tears. So this is a huge kind of problem. A lot of other things can cause pseudobulbar affect as well. Dementia, like CTE, this is being more and more recognized in the NFL. CTE is chronic traumatic encephalopathy. Chronic, right? It happens over and over. Traumatic injury. Encephalopathy, it's in my brain, right? My brain is messed up. This is true of boxers. Boxers were kind of the prototypical. So there's 2 ways to get TBIs. One is to get a big blow, right? And the brain rattle really hard. The other is blow, 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 right? And that's boxing, that's football, right? And all of those add up to an irreversible dementia that then kills someone. And that's chronic traumatic encephalopathy. And you can see some documentaries on this on Netflix. There's that documentary about that one football player who had personality changes. I can't remember. I think he was a defensive end or something. I can't remember his name. But a lot of football players will suffer from this. He might have also been kind of antisocial. When I saw the thing, I was like, maybe he's antisocial. But I mean, he did hit his head a bunch, so it's kind of hard to say, right? And they look at these guys' brains after, and they're just all messed up. Now, this is the medical costs, so we've already gone over that. That's why they're important medically. But this is really the key for us, is why is it psychiatrically important? And the fact of the matter is it's very, very frequently associated with psychiatric symptoms. 48% of patients have an axis 1 disorder when assessed 30 years after their head injury. So if someone gets a head injury, there's a 50% chance, essentially, just flip a coin, whether they have depression, PTSD, psychosis, mania, anxiety, cognitive impairment, personality changes, insomnia, or suicidal thoughts. So, and then the breakdown from there, I put it in the slides of the notes that will be given to you after. Depression is the most common. It's around 30 to 50%. They have these really wide ranges, which almost make it meaningless. Anxiety is like 7 to 40%. Those are the most common causes. But look at suicide, 15% attempt within 5 years after a traumatic brain injury. That's a very high number of people. And that's an attempt, right? This isn't thoughts. An attempt is way far away. This isn't thoughts. This isn't a plan. This is like doing those things. And so it shows you the level of impairment and the level of severity with that too. What are some risk factors? What makes my patient, when I have a patient in front of me, what makes me think, you know what, even though they said and this happens very frequently, I'll say, you ever get your bell rung? You ever have a head injury? And they'll be like, no. And I'm like, I just really think they do, because they ride a motorcycle, because they've been in abusive relationships, because they've fallen, because they just love football and they played football their whole career. Or they just seem a little off, like, man, their attention's really messed up, I'll keep asking them, and I tell you, oh, I've never hit my head. But you know what? 5 years ago, I got hospitalized for a week and I was in a coma because I fell off my motorcycle. But I didn't hit my head. I think you probably hit your head. I don't tell that, but it's like, okay. So you kind of just keep pushing. If you think, this person just seems a little off, they're kind of all over the place. And then you just have to ask more specific questions and kind of loop around. The most common cause of traumatic brain injuries is falls. By about 40 to 50% of traumatic brain injuries are caused by falls. Less by intimate partner violence. The second most would probably be motor vehicle accidents or sports. And this is, again, one thing that even a lot of doctors, a lot of family doctors, a lot of internal medicine doctors don't know about, because you see their kids playing football, right? And you see their kids boxing. And if they knew about this, I don't think they would have their kids playing football and boxing. The most common cause of actually sports-related TBIs is actually bicycling. Because you just fall off at those high speeds and you hurt yourself. And so that's actually the most common cause of TBIs. TBI pathology, we've already talked about this. The first injury, hitting the back of the head. The second injury, the brain reverberating and hitting the front of the brain here. There's actually some unfortunate anatomy going on here. So if you get hit in the back, you have little bones here. So the front of your brain kind of scrapes over those bones too, damaging that. If you're hit in the front of the brain, it's actually a lot better, because the back of the brain, this is really smooth, right? The surface of the skull is really smooth. The surface of the skull here is actually really jagged. So it's kind of nicer getting hit in the front going to back. And then of course you have that diffuse axon shearing. Now what is this? This let's say is an axon track. So when the brain reverberates, basically you're just cutting these. Now the only way to pick this up, if you CT scan this person's brain and there's no bone fractures and there's no bleeding, it's going to be negative. Your brain's great. You had a CT scan, it's negative. If you do an MRI of this person's brain, it's normal. But they've just had a significant traumatic brain injury. The only way you can actually tell is with a specific type of MRI called diffuse tensor imaging, which right now is experimental. You can't even order this. This is like just what studies do. and it looks at the white matter tracts. And then it'll show how severely they'll affect it. And you're like, oh, okay, there's severe injury here, there's severe injury here, there's severe injury here, there's severe injury here. Oh, there's only minor injury here, here, and here. But if this was just a regular MRI, oh, this is a perfect brain. If this is a regular CT scan, this is a perfect brain. So this messes up people too, because they'll bell rung, they'll go to urgent care, all the studies are negative, and then they'll get sent out, and they're like, oh my goodness, I have a headache. It's been going on since this happened to a friend of mine. He had a headache. He got up, he hit his head on the corner of a TV, and he had a headache for like a month. He was like, do I still have a head injury? Yes, you do. As long as that headache lasts, you have a TBI. That TBI is still evolving. You're still losing brain. And so these things can actually last up to 6 months, up to a year even, before they get better. The brain takes a long time to heal. What can we do? There's actually the most amount of evidence is for exercise. Here's a couple good articles on that. I have another one if you're ever interested. CBT, maybe. Medications, maybe. The problem is this is actually really hard to treat. Our treatment in psychiatry in general is not the best. I think we should admit that. And then our treatment for TBI is even a step below that. There's some experimental treatments like supplements like melatonin and acetylcysteine, methylene blue, omega-3 that have some evidence behind them. But there's not a lot of robust evidence. And honestly, this area hasn't been studied very well. So definitely a lot more research needs to be done, since 1% of the United States population suffers from this. So that's traumatic brain injury. So we've now gone over sleep apnea, traumatic brain injury. Next will be substance use. The first thing I wanted to just show you was the difference between a substance use disorder and substance use. So there's a difference. At the bottom of the pyramid here, we have abstinence, and then we have low risk use. So this would be someone drinking 1 beer every other day, that one standard beer with a standard level of alcohol content every day. That would be low risk. Risky use, this would be someone drinking a nice IPA probably every day, right? Where it's like 7, 8%. That's risky use if you do that every day. It's not a substance use, but it could turn into a substance use. So this is someone that you're just thinking, okay, I'm just going to keep track of this. This could turn into a substance use. It's risky, but it's not harmful. And then the threshold for substance use is now harmful use. Now the question is, what causes a crossing of that threshold? And we'll talk about that in a second. But I just wanted to put this all in kind of that you can use things but not have a substance use disorder. But that's actually different. And then you rank the substance use disorder mild, moderate, severe. It's based on consumption, and it's based on the consequences of your substance use. So risky use doesn't have any consequences. Substance use disorder has consequences. Why don't we go over those consequences first, right? So how do I know the difference? Well, the DSM criteria. And there's 11 criteria. One is that you use it in larger amounts over a longer time than what you want. It's like, have you noticed, the way I ask this is like, have you noticed you haven't been able to kind of stop, even though you don't want to drink as much as you do? A lot of time they'll say yes. Persistent desire, unsuccessful attempt to cut down. I just haven't been able to stop, even though I want to. A great deal of time spent to obtain, use, or recover, right? I just always feel hungover. Or I just, I always feel hungover. It's fine. And I can't go to work because of it, right? Now you've just hit 2, because you've also hit reduction of important social, occupational, recreational, right? You're hungover, you can't go to work, you're recovering from the substance, you have withdrawal, and you have, so some of these kind of stack on top of each other. And reduction of important social, occupational, recreational. Recurrent use, a craving, right? So that's really common. I just want to drink right now. Recurrent use resulting in failure to fulfill important obligations at work, home, and school. Continued use despite interpersonal problems. You're always getting in fights with your wife over this, right? That's continued use. Reduction of important, I already said that. Recurrent use despite physically hazardous. You keep getting those DUIs. If someone's got a DUI, they probably already have moderate. It's like, you can figure about 5 of these things with a DUI, because you're, especially by the second, you're just using it again. It's physical problems from the use, right? They obviously crave it because they're using these risky situations, and they're probably not doing super great at home and fighting with their wife, right? If you keep if you keep getting DUIs like that. And of course, tolerance and withdrawal. Moderate, I just remember that. Moderate is 4 to 5. If I know that, then I know severe is anything greater than 5, and I know mild is anything less than 4. And now I know mild, and I know severe, and I know moderate. So that's a substance use disorder, and it's really this impairment in functioning. Oops, okay, we'll go back. So why is substance use important? This is the other than traumatic brain injuries, this is the other killer of the young, really. 40% of traffic fatalities are attributed to substance. And surprisingly, if I was going to ask you, what is the most common substance implicated in traffic fatalities? It's actually marijuana. And it's probably only going to be increasingly prevalent now that marijuana is becoming legalized in other states. So marijuana is actually greater than alcohol. 50% of state and federal prisoners have a substance use disorder. So it's very comorbid with antisocial personality disorder. If someone has a substance use disorder, the first thing you should think is this person also have antisocial personality disorder? 2/3 of intimate partner violence involve a substance. 100 to 200 costs big bucks. 200 billion every year is spent on healthcare costs for the use of. So this isn't medical costs. This is just people spending their hard-earned money on tobacco, alcohol, illicit drugs, and opiates. So this includes all money. This was from a PCSS presentation. This is actually really good. It's in my references as well. There's the society, PCSS, they've created probably about 40 hours of free online videos that have some of the most up-to-date information on substance use, actually. Very good, very good. And then 7.8% of Americans had a substance use disorder this past year, so very high. And then substance use is a very common cause of depression and psychosis. It goes both directions. So medical causes are the result of substance use, and then psychiatric causes are the result of substance use. And then also psychiatric causes make people more prone to substance use, right? So the substance use can cause psychiatric disorders, and psychiatric disorders can cause substance use. And that makes it even more difficult to kind of parse through, right? These are odds ratios from a study that shows you the odds of certain medical and psychiatric conditions. It's interesting, right? So look at the cases and look at the controls and look at these numbers. And basically the odds ratio is, you know, how many times more are you likely of getting this if you have a substance use disorder. And look at the one that's the highest. Let's see, here it is, 18. Psychosis. Is that psychosis or is it, no, depression, anxiety? I'm having troubles. Yeah, no, it's psychosis, huh? It's even higher than liver cirrhosis. So, you know, people think like, oh, I'm messing up my liver. You're not messing up your liver, you're messing up your brain, right? That's really what you're doing the most. Depression, next highest, right? So anytime someone is depressed or psychotic, one of the first things I think is, are they using something? And that's even if they say no, and even if their UDS is negative, I'm still thinking that because it's so prevalent, and because UDSs don't pick up things like spice, which is becoming increasingly common, or synthetic cannabinoids, or fentanyl. Fentanyl, the UDS isn't going to pick up on that. So there's stuff that our drug screens don't pick up on. I remember this one kid in the ER. They were in the ER. They were like 14. So, you know, a common demographic for like inhalants and some street drugs that don't show up, like synthetic cannabinoids. There was an animal print wall on the ER screen, and I was like, all right, what are you using? After I, you know, built up some rapport, I'm trying to be the cool guy. What are you using? You know, what's going on? What's cool? What's going on the streets these days? You know, how'd you get in here? And they're like, I'm not using anything. Oh my gosh, the zebras on the sheet, they're alive. Like, I'm like, okay, anytime you have visual hallucinations in general, that's not primarily psychiatric. Visual hallucinations is a hallmark of medical, like substance use. They're like, these zebras, the shapes, do you see them? I'm like, what are you using? What are you using? They don't tell me. Their UDS is negative. They definitely were using something, right? So it's just so common. I mean, again, what we know from the last lecture of what is the age of onset of schizophrenia? What is the age of onset of bipolar 1? The other things that cause psychosis, right? That are mental health related, usually later in life, not 14 years old. 14 years old, this person's using spice or something like that. This is a table that shows you how it goes in the other direction. So what disorders are comorbid with drug use? So we have here, the highest number is antisocial. These first ones, for some reason, they're comparing alcohol use to other drug use. So yeah, actually alcohol use is really comorbid with other drugs. It's the most comorbid. But then of the psychiatric conditions, the most comorbid is actually antisocial, clocking at about 3 times more likely, right? The other ones, bipolar 1 and nicotine. But look, the other ones aren't as actually comorbid. So, you know, the patients will come and they'll say, I'm self-medicating my anxiety. I'm self-medicating my anxiety. That is possible, but it's interesting because every patient that uses substance tells me that. And the numbers say that more patients should actually be antisocial. Right? That's actually the most common thing here that I should be looking for, despite what my patients are saying, that it's due to their ADHD. I just had a patient that was literally high on methamphetamine saying, if you just treated my ADHD and gave me Adderall, then I wouldn't use meth. And I was like, yeah, I'm not going to do that. I'm not going to do that. Risk factors for substance use, huge genetic component. Up to 3/4 of this is due to family. So getting a good family history for substance use only raises my index of suspicion more. If dad is doing it and mom is doing it, you're going to be doing it. And so, you know, this is something that we even have to look out on our own, you know, as clinicians. Access is the biggest. 97% of people with a substance use disorder started using prior to the age of 21 years old. So basically, why does a 13-year-old use marijuana? Because dad is using marijuana. His pipe is just laying around the house, right? Why does a 13-year-old, why is the most prevalent a substance for 11 and 12 years old inhalants? Because you can go to the store and buy some whipped cream, right? And then you just inhale it. So it's like, it's kind of at this age, the younger you are, what it's most access. When is when are people most at risk of alcohol use? 18, 19, 20. Why? Because all their friends are 21 now, right? And now all their friends can get alcohol for them, or they can go to those parties. So once you get past 21 years old, you've kind of already gone through the most difficult part, because if you've had friends that have access to them, you've kind of said no. And if you haven't, then you've partaken, and that's okay. But it can put you just at higher risk further on. So if you get through 21 years old, you're basically okay. Now, have I seen, I don't know why this happens, but I've seen a bunch of 60-year-old ladies, and they have started meth for the first time. And I have no idea why at 60 years old, they're like psychotic out of their mind, or they're like, look at all the bugs on me. And I'm like, there are no bugs. But there's meth in your system. And I'm like, when did you start using meth? They're like, I was just feeling down, and I just started using this last year. And that will happen too, but by and large, this is the pattern, you know, 97%. What are the consequences? This is, again, kind of like, why should I care? So these are people that use meth, and these are brain scans from the study of Volkow, 2001. And this is how dopamine is lighting up. So you have most of your dopamine in your midbrain regions. This is like where the reward centers are and everything like that. And if you look at the color here, I'm colorblind, so you're gonna have to forgive me. I think this is red. And I think this is red here, or orange, whatever you want to call it. And this looks like yellowish green kind of around it. So these red regions are really a lot of dopamine. And this is normal, right? So this is like hopefully all of our brains. We're not using drugs. Now, this is a person who uses meth, and they're a month free of using the meth. So they use it, but now they're a month out. They still do not have really any hot regions of dopamine in their brain. This is a year later. So now they have hot regions of dopamine in their brain, but does it look the same as the control? No. So drugs alter your brain. And like I said with TBIs, the brain is very slow to heal. Will it heal? Yes. Will it be back to normal? Honestly, with meth, the answer is no. One meth use kills axons. That's all meth does. It kills axons. Some people have a lot of brain material. They can handle it. Some people can't. I've had patients that have used meth one time and now they're psychotic for the rest of their lives. So it's they're kind of playing a game of Russian roulette. And this is true of the other substance as well. Meth is just an extreme example, but this is true of alcohol. This is true of marijuana. These are making chronic brain changes that take months to get better from, months and months. So it's a big deal if someone's using chronic marijuana use. It's going to take a month, maybe 2 months, just for that marijuana to leach out of their fat and to get out of their bloodstream after their last use, because the marijuana drug itself stores in your fat and it can take months for that to get rid of. And now those brain changes can take effect, which are going to take even more months, right? Now that the marijuana is completely out of your system. So this stuff just takes a really long time. And if this is the cause of their depression, it kind of sucks because my hands are kind of tied. I can give you an SSRI, and that will help the brain, but like this isn't going to happen with that SSRI necessarily. It's really just going to happen over time as the brain heals on its own. And so abstinence really becomes key. The only part of treatment that I wanted to talk about, of course, we could talk a whole hour about substance use, and in the case of PCSS and that whole online thing, they talk 40 hours about it. So, we could talk a long time about this, but what I thought that I could kind of contribute is just a bird's eye view, because this may be new to some people. It was new to me up to even about like a year ago. And that is treatment options for substance use and looking at it from a systems perspective. So of course, treatment for substance use, meds, therapy, right? In a nutshell. But then other than meds and therapy, what other treatment options are available? And really the answer is the milieu, where they are located. And I think what I want us to recognize in looking at this is where we are right now is 1. We are in outpatient services, right? And that's where we are. And where can we go in substance use? We can go up to a 4. 1 is a lot less than 4. So there are going to be a lot of patients, and I just know this from my practice, that I am not going to be able to help because they have a severe substance use disorder. And this is what I tell them the first time they meet with me. I think you have a substance use disorder. I think that I'm really not going to be able to help you very much. I enjoyed talking to you right now. I can tell you enjoyed talking to me. And if you want to keep working with me right now, we can keep working together. I think some doctors will say, no, I'm not even going to touch you with, a 100-foot pole, which is a shame because these patients need help and they need to learn that us as mental health practitioners are warm toward them, we're friendly toward them, and we legitimately care about them. And so that's what I try to do is I try to build rapport, but I also try to show them where I am on the spectrum. And I just use it with my words, but there's things out there like residential, like partial, like intensive outpatient. And a lot of patients need those things. And I think with what's going on with you, I think this anxiety reason, the reason why you came to me, is a product of the brain changes that have happened because of your drinking. And I'm not going to be able to really help you change that. And I think you're actually going to need a team of people that are going to come around you that are really going to be able to help you. And so I kind of start the referral conversation and I test the waters, and I'm pretty direct about it because this might be the only time I interact with them, right? And then, they have these other services. So they might need to go to detox, which is a 4, right? Because you can have seizures and die from alcohol withdrawal. And opiate withdrawal, you're going to feel the worst you've ever felt in your life. So you probably don't want to feel that way, and you probably want to go to intensive inpatient. You stay there for 7 days, you finish your detox. Now you should probably go to residential, a 3.5 or a 3.3 or a 3.1. All of these are residential, they're all the same. You live there, you live at the place, it's sober living, right? That's what it is. Maybe you're done there, now you need to go to a partial hospitalization. And the problem is these, there's a lot of sober livings, but the problem in medicine is we don't have a lot of partial and intensive outpatients. So you go from like a 3.5 to a 1 now, right? Now that you're a patient. I just got out of rehab, doc. I'm ready to talk to you. I'm like, oh no. Because that's what do you expect? Like, how do I expect this patient, you know, they haven't gone to partial, I mean, they haven't really gone down the line. And if you go on the website, this is straight from ASAM, ASAM. This is ASAM levels of care. It's in the footnotes. It's in the summary. And you can look, they tell you in each of these, you can click on the 4 button, you can click on the 3 button, you can click on the 2.5, and they tell you what kind of patient is ideal for this setting. And I got to tell you, what kind of patients are ideal for R1? Not too many, right? 1 is basically like you have a substance use and it's not like really affecting your life that much. Now, partial hospitalization, what's that? This is you spending 5 hours a day in a program, living at home, because it's a partial hospitalization. So you live at home, but you spend 5 hours of your day doing programming at a hospital type level. Maybe even going near inpatient. And then intensive outpatient, it depends on the program. Ours at Loma Linda is like 3 times a day in the evening for 3 hours, so 9 hours a week. So that's a lot different from, you know, at most outpatient, I'm gonna be seeing patients once a week, maybe twice a week, if I think they're really unstable and they continue to say, I don't wanna do anything else. But intensive outpatient is already more than that. This is 3 hours a day, 3 times a week. Partial is 5 hours a day, 5 times a week. This is you're living there. This is like 24 hours a day, right? As is medical inpatient. So I think knowing these levels is just really helpful, and knowing where we can help people is kind of one of the biggest things. And knowing when we need to tap out and just say, you know what, this is beyond me. I can do this, but your trajectory is not going to be super good. And we can talk about how in future lectures or future talks we can talk about how to move patients through the pre-contemplative to the contemplative stages and kind of stuff like that. This is the last subject we'll be going over, and that's delirium. This picture is there because delirium can present as anything. It can present like anything, and it's very dangerous. What is it? This is the textbook definition. If you open up any textbook, if you Google it, this is what it should say. It's an acute onset, so it happens. Before surgery, I was fine. After surgery, I wasn't. The classic thing I get in the hospital from all medical staff at all levels is, it's so weird. The patient was fine, and then they weren't. And I'm like already thinking before they call me it's delirium, because I'm in the hospital, right? And then they say that, and I'm like, oh, this is delirium. And then I talk to the nurse, and I say, did the patient know where they are? And then they say they do. And then I go in and I say, do you know where you are? And they're like, I don't. That's kind of like what every delirium case looks like in the hospital. So it's acute onset. It's waxing and waning levels of attention and concentration. It's so weird. They know where they are and then they don't. I don't know what this is. That's delirium. That is the hallmark of delirium. Why is it important? Well, there's a dose effect. The more delirium you have, the more severe delirium, the longer it lasts, the more brain is dying. So you're talking about brain death. It can last months. So untreated, it can last up to 6 months. It increases lengths of stays in hospitals. It totally increases tons of costs to the healthcare. You have more medical problems and you die more. And you might never come back. You might have permanent neurocognitive deficits once you come back for your delirium, depending on how much brain has died. What does delirium do to? It's due to everything. It's literally due to everything everywhere. It literally could be due to anything. I think I have a slide. Do I have a slide here? No, I don't have a slide. But if I had put a slide, there would literally be 100. Any medical condition you can possibly think of can cause delirium. We'll go over the risk factors in a bit. Prevalence. So one of the biggest risk factors for delirium, and one of the biggest things that can cause it, is getting older. Something I think we all want to do. Look at the statistical probability of delirium at, like, let's say, like, I'm kind of putting a fake line at 90. There's like an 85% chance that I'm going to transition to delirium at 90 years old. So the fact is our brain just becomes a little weaker when we get old. This is how I say it. It just doesn't have as much reserves. It just can't operate at 100%. And so basically any insult to the brain at that point, like that diabetes that you got at 50, now it's sending you into delirium. That little fall that you had at 50 that, you know, didn't affect anything, now it's sending you into delirium. And so this is just going up astronomically as time goes on. In the hospital setting, it's so common. 10% of patients driving the hospital, 20% of patients, 1 in 5 patients on the medical floor have this. Most of them are undiagnosed. And 4 out of 5, anywhere from 4 out of 5 to 9 out of 10 patients in the ICU. About 50% postoperative. It depends on the operation. Risk factors, getting older is a big risk factor. Prior brain injury, so if they hit their head before, they have a history of schizophrenia, that puts them at greater risk. 4 more medications. You show me an 80-year-old that's on less than 4 medicines, and I will just like be so happy. Most 80-year-olds are, right? If you have diabetes, you're probably already on like 4 medicines, and now you had your heart attacks, and now you're on like 8. And now you have another risk factor other than just getting old, being delirium. And then just being sick. So not only it's like a double whammy. You're getting older, you're getting more medical illnesses, and you're taking more meds. Right? It's like a perfect storm. I just put this slide in because I think it's hilarious. So this is the pathophysiology of delirium. Like, way to put in a chart in a book that is just totally grossly overcomplicated. Really, it boils down to 2 things. One is you have increased dopamine up to 500-fold. So just like way too much dopamine. And then the other thing is you have decreased acetylcholine. Now, if you look in this book, they'll also say every other neurotransmitter in your brain and all the changes, but these are kind of the 2 biggest. And so basically you get too much dopamine and too little acetylcholine. Acetylcholine just goes down over your life. So you can see that in this box. Increasing age already leads to decreasing acetylcholine. And then some medications can decrease acetylcholine. A lot of medications actually can. So those are ones that are particularly harmful for the elderly. What can we do? Meds help, environmental changes help. These are some of the other ones. You basically just try to make sure they eat, make sure they can move. I would look over their med list to see if there's any anticholinergic, because that's important. Make sure they can see, they can hear. The way I think about it is the more grounded I am in reality, the less chance there is of delirium. So that's the problem with going to a hospital. You go to a hospital, there's lines in you, there's people coming and going. You don't know who they are. And so then that kind of takes you out of your reality. And because you're taken out of that reality, you need things that ground you. So having a loved one there saying you're in the hospital right now, or having a favorite blanket or a stuffed animal, or just something that grounds you, like, I am John. I love this music. I love this like stuffed animal. I love, my kid, right? That kind of stuff actually goes even further sometimes than the medication goes. Adequate intellectual stimulation. So you want them to be thinking, but you don't want them to be vegging out and just watching TV. You're kind of walking a tightrope because pain causes delirium and then opiates cause delirium. So you don't want them to be in pain, but you don't want to address their pain so much because meds also cause delirium. So sometimes you're kind of between a rock and a hard place here. Avoiding some meds, and then daily awakening. So a hallmark of delirium is disordered sleep. So some people will call this like sundowning. That's a common phrase that's used, but it's really delirium. And their sleep cycle will get totally flipped. So they want to nap during the day and stay awake at night. So one thing I give to almost all my patients with delirium is melatonin, very low doses. That helps turn the sleep cycle back. And then another thing is you got to give them light during the day, especially noon light. If they can get outside, that's great if they're at home. And then you don't want them to take naps. You can take short naps, but you don't want them to take long naps. You don't want them to you don't want them sleeping all day and staying up all night. Because if that happens, they're going to be confused the whole night. It's going to be very bad. So we're done. So we can review some of the things we learned. A 50-year-old male presents with new onset depression. He has hypertension, daytime somnolence, and insomnia. What medical condition should you rule out? So now hopefully it's clear that we should rule out obstructive sleep apnea. What is the goal?